Welcome. I'm Shelley O'Connor with Hospice of Waterloo Region, and this is Advanced Care Planning through a Healthcare Lens. It's backed by popular demand. We have four great panelists to kind of walk us through the healthcare system with a lens on, okay, how does advanced care planning, how do these conversations work as you work your way through the healthcare system? So we're very excited. We did a similar kind of session last year, and it was an incredible discussion. So we have three questions that we're going to ask of the speakers, and then we'll have a question and answer period. We're going to ask you to mute your lines while they're speaking. You can put your questions in the chat, and we'll go through those first once we get to the Q&A, and then we'll open it up after that to hand signals and waving if you have a question to ask, and we'll manage that. I'd like to start, though, as we do with all of our sessions, with land acknowledgement. Hospice is committed to this, and I think we've all been exposed and had lots of conversations about what we're trying to do here around reconciliation. So I'm going to read this and give you some more food for thought, and hopefully it sets a context for how we go forward. While we may be connecting virtually from across the region, we would like to acknowledge that Hospice of Waterloo Region is based on the ancestral and traditional territories of the Anishinaabe, the Haudenosaunee, and the Ottawandaran and Neutral people. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging them reminds us of our important connection to this land where we live, learn, and work. As citizens, we have a responsibility for the stewardship of this land, and I invite you to join me in considering our collective role in the stewardship of this Mother Earth and in the important process of reconciliation. So with that in mind, setting the tone, I'd like to turn it over to we have our ACP team here, our ambassadors, who are available all the time to go out into the community to do a variety of presentations, and we can talk about that at the end, but they also are incredible facilitators. So I'm going to turn it over to them. In terms of our panelists, I did send out the profiles of each of them and the team so that you have that information, so that we won't go through it again in detail. But I'm sure if you have questions for each of the panelists about their roles, we'll have time in the presentation for that. So I'm going to turn it over to Deb to get us started. Please mute your phones, and if you want to turn off your screen at this point, that's fine, but we would like you at least to be muted. Thanks.
Hello, everyone, and thanks so much for joining us. I'd like to echo what Shelley said and invite you to look at the bios and extraordinary experiences of our panelists today. We have virtually decades and decades of experience combined here with us from varying community settings. That is just a wealth of experience here. So we have three general questions that we'll ask each panelist to respond to in sequence. We're trying to limit responses to about 5 minutes. So as we move forward, you may see us giving a timeout sign to let people know that they're approaching their 5 minutes. And we're asking that folks try to keep two hats on during our presentation, both becoming a substitute decision maker and asking someone to become your substitute decision maker. So that's sort of the parameters of today's presentation. So let's get started. And so I'm going to start with Brenda, if I could, and ask you to respond to the question about what would be expected of a substitute decision maker in your setting, and what would the role look like. And as has been our experience, that stories are the best way to move forward in explaining that. So you're up.
All right. And my apologies ahead of time if anybody's shocked by my bluntness. I've worked in healthcare for 33 years, and although it says ICU, I've actually worked in just about every program at Grand River Hospital that I could have, predominantly as a physiotherapist for almost 30 years. So my lens will come to you about the hospital as a whole, not just the ICU perspective. when we're talking about SDM POA. The first thing I want you to know is that as healthcare professionals, we do this very poorly. So if you are relying on the healthcare professional to guide you through this when you're in a moment of stress, that's probably your first mistake. Not because there aren't some great healthcare professionals who know this legislation well and follow it, but because if you've been watching the news or have accessed healthcare lately, it's a pretty harried place. People have high workloads. They're running around trying to get a lot done, and they don't always tick the boxes in the way they're supposed to do with following the correct legislation. So one of the things you need to understand is the difference between an SDM and a POA. SDM, substitute decision maker, is a fixed hierarchy via legislation. And as healthcare practitioners, we don't have any option if you don't have a legal power of attorney. So if you haven't taken the time to go to a lawyer or to fill out the free forms that you can fill out designating your power of attorney for personal care, we must follow the Substitute Decision Makers Act and follow the substitute decision maker hierarchy. So if you have children, that is all of your children, and they all must agree. We can't pick or choose one or the other. I'd like to have $1 for every time in my career I've said a neighbor can never be a substitute decision maker. Doesn't matter if that neighbor is the person who's got their groceries for them their entire life and is their only main support. A neighbor can never be a substitute decision maker. So if you are in a position where the Substitute Decision Maker Act hierarchy does not meet your needs, then you really, really need a power of attorney. That's the direction you have to go if you want to designate the right person to make the decision for you while you're doing that. The other thing to know is, and this is also poorly managed in healthcare, is a substitute decision maker or a power of attorney only come into play if the patient themselves has been deemed incapable of making that decision. So not to underscore your value, because obviously support and advocating for someone is important, but if there's a capable patient, that capable patient should be making the decision, regardless of age and diagnosis, including dementia. And the benchmark for capacity is that the person understands the intervention being offered, their situation, and the full risks and benefits associated with that. So although there are lots of people who might not know the day of the week, and they might not know where they are, if they understand that they're in a dying process and the implications of their decisions, they would be deemed capable to make that decision, because they just have to understand the decision putting in front of them and all the risks and benefits for that. So one of the things I want to give you just a really quick story is I have a friend who had an elderly mother-in-law in 96 living in assisted living. And recently I made the mistake of asking her how mother-in-law was. And then within 3 days, she was calling me saying her mother-in-law had been found on the toilet, because that's where you're all found on the toilet, unresponsive, massive stroke, was taken to hospital. There are 2 children in this family, my friend's husband, and then his sister, who was the closest person to that hospital, so showed up at the hospital. Throughout this woman's entire stay, not a single healthcare professional asked who the POA was. They just assumed that the daughter at the bedside would be so. So that's my first lesson to you is, if you are the substitute decision maker or power of attorney, I suggest you create a packet of your relevant documents. Even if your person you represent is well and hearty and it's all good, it will stand you in good stead to have everything ready to go, that if you get a call for a hospital and you're in an emotional state and worried and you're not going to think rationally, if you have your package ready that has your POA documents and all the things we're going to talk about in the next question about what your person, you're the substitute decision maker, said they wanted, that will help you be prepared to know that you can manage that decision as you go. The next thing I would say is that the next day her husband, so the daughter showed up and said, I want DNR, because they knew their mom very clearly. This was a massive stroke. She was unresponsive. She said, I want DNR. Son shows up the next day. Patient has an IV in, and she's on IV blood pressure medication. And son freaks out and says, I don't understand why, because the family misunderstood the difference between DNR and comfort care. So having a clear understanding of what all the terms mean and what your decision-making means is really, really important. DNR only means if you have a critical event that requires utilization of life support, you do not initiate those various forms of life support, which is very, very different than coming to a hospital and receiving care, active care for all other situations. So putting an IV in her mother-in-law and adding IV blood pressure medication probably prolonged her dying process by a week, rough estimate. So that would be the other thing I would say is substitute decision makers, I think, need to have a real sense of what the person wants. I would say create a list of all of the things, the questions you want to ask and things you want to know that represent the values of the person you're representing, and ask as many questions as you need to ask until you feel you understand the situation fully, because we will give you everything in jargon and in short phrases, because lots of healthcare practitioners are not comfortable with these conversations. They should be. It should be taught in school, it should be trained, but they're not. So a lot of them are trying very hard to get the bad news delivered fast and get out. And you need to feel like you're empowered to stop the discussion and reframe every question you need until you feel like you have that answer, so that you can represent the known wishes of the person that you are now the representative of. And that's the last thing I would say is your responsibility as a POA or SDM is not what you would want for yourself. It's if that person was mentally capable and in front of you right now and they heard the same information that you heard, what is the decision they would make for themselves? You are their proxy for their values, not imposing your values.
Thanks so much, Brenda. If we can back some of that information now out into the community and ask Ann Bartlett, Ann Beatles from the region of Waterloo Paramedic Services to jump in now and talk about what SDMs look like in her world.
Thanks so much, Deb. Yeah, in the paramedic services, I bring a lens from both frontline 911 paramedic services as well as our community paramedic program, where we now go into clients' homes and support them in a non-emergency basis. So we're really seeing families earlier in this process, and our goal is to help navigate and support as best we can. Typically with the substitute decision makers, our ideal situation would be having somebody who's had those early discussions and planning with their loved one, their family member. It very much streamlines the process to open the lines of communication, help our paramedics know what the desires are, know what the treatment plans are, goals of care. In my experience, I've seen situations that have been very well thought out. And those discussions typically happen when people were healthy. Much to play into what Brenda said, these discussions need to happen early and be ongoing as conditions and diagnosis change. If you have this when you're healthy and it takes that awkward tone out of it, they're not comfortable conversations, but we plan for every stage in our life. We plan around graduations, births, those sorts of things. And there's this taboo that we don't talk about death and dying process and chronic illness. So the clients that have had experiences that I think met their needs, met the needs of the family, were ones that had planned. And sometimes in our rule that does incorporate the DNRC. So for us, that's the DNR, Do Not Resuscitate Confirmation Form. It's a provincial form that individuals can discuss with their doctor, their NP, their nurse practitioner, healthcare team. And it's a discussion to have about what you would like in that situation where you're not able to make a decision for yourself. In EMS, that quite often happens when we arrive and someone is unconscious, if there's been a long-standing illness, that there's not heroic resuscitative efforts. Quite often we see in media that, there's CPR takes place and somebody comes back miraculously. But unfortunately, that happens very rarely, and it's quite an aggressive process. And many individuals don't wish that. They don't wish the rigors of CPR and being on a ventilator, breathing tubes, those sorts of things. And it can be traumatic for the family as well. In saying that, though, it is the patient's decision. So I did appreciate the discussion on the POA, because quite often what we will face being paramedics in the community is arriving at scene, someone has deteriorated, and the individual will tell us, I'm the POA, the documents of the lawyer. So it's good information to have, but in the province of Ontario, for our paramedics to honor those wishes, we have to have a legislated DNRC form, which has a serial number, and it has to be completed and signed appropriately by your healthcare professional. And the positive about that is that a discussion takes place prior. So there's that communication with your healthcare team. A copy of that should be somewhere accessible. You know, some people don't wish to keep their medical information out in the home, but on a refrigerator with your medication blister packages in a purse, and then telling that to your, you know, whether that be a family member or someone who lives with you, where that document can be easily located. At this time, we don't have a registry provincially, so that's a challenge, and sometimes finding that document. So knowing where it is, having that, and letting others know is really key. And the communication piece with substitute decision makers, knowing what the wishes are, and Brenda tied into this, it's not your wish. You know, it can be a challenge. And so often what we hear is, my daughter is my substitute decision maker because she's the oldest and we have a close bond. Well, if you have 4 children, this is a joint effort. And if you foresee that there are differing relationship levels, if there are conflicting views, this is really a time when you are well or early in a trajectory that you have those discussions, and let them know. And we often see dynamics where there are newer blended families. So when mom or dad have remarried later in life and children have a different opinion of what the care and treatment will be for mom and dad, those are challenges. And when they're not discussed, by the time 911 calls, there's a reason. This is an emergency typically. And that elevated emotion, most people, it's difficult to deal with the situation at hand, let alone trying to consider values, roles, wants, wishes. It's very difficult. So I encourage everybody to have those conversations early. And if that's something you're open to, and the DNR piece is something you'd like to consider, to include your primary care practitioner and ask for more information to see if that's an appropriate choice.
Thanks, Anne. And now we'd like to move to Elaine to give us some perspective on what substitute decision makers might face in the long-term care setting.
For sure. And I think much has already been said, and my comments will very much simply reinforce what Brenda and Anne have already stated. So I am here in my role at Fairview and Parkwood Seniors Communities. As well, I'm a daughter of a wonderful woman who lived for 13 years between retirement home and long-term care. And so before I get into the expectations, I'll maybe shift a little more to what happens when people move into congregate living and what that actually looks like. We do find that most residents who come into long-term care have a substitute decision maker. However, residents who move into independent living or retirement home often do not. And you would wonder why. We're having all of these conversations about ensuring that you have a substitute decision maker. But I think in our conversations with elders who move into independent living and retirement home, we understand that this has not happened because the elder feels that by signing the papers, they're already giving up their independence. And they're often not ready to share all of their wishes or financial information with their children or a child or a potential substitute decision maker. And so it's really important for all of us to understand that just because someone's been named as a substitute decision maker, it doesn't mean that they start making decisions. Just because the papers are signed, it doesn't mean the individual has given up their rights. And so that's incredibly important for all of us to realize. In today's world, on the other hand, as I mentioned, residents who come to long-term care often are coming from hospital, and they have perhaps gone through the process as they have been in hospital, or because there has been an event or a health care issue that has caused them to consider putting this in place. And so important to recognize that this should be done long before this point in time. So shifting to specifically to the question, in congregate living, I think our expectations and perhaps not our expectations, but the expectation that makes living in a congregate setting so much easier is for a substitute decision maker who is able to take responsibility for decisions based on, as it has already been said, the residents' wishes and their beliefs, even if that is not how the substitute decision maker feels themselves. We often see substitute decision makers making decisions based on their own personal views. And so it's really important that the substitute decision maker makes decisions only if the resident is not capable, and then makes those decisions based on the resident's wishes. And I always think about my own mother and being her substitute decision maker. She had everything written down, and some of it was in her own handwriting. And it was really reassuring to me to know what her wishes were as some of the decisions became difficult. But I will, and again, this happens to us. We've talked about capacity already here this morning. I will very much mention that while I made financial decisions for my mother for many years, I did not make decisions with regards to her care because she was able to make those decisions. And so it's not that all of a sudden a substitute decision maker takes over. But as her memory declined, I made more and more decisions. And eventually at end of life, I needed to make all of them. The second piece with regards to congregate living that I think is so incredibly important is the substitute decision maker is a care partner with the staff, especially during times of transition. Specifically at the time of admission of a resident, it is so much easier, especially with the paperwork, if the substitute decision maker, even if they're not required to make decisions, if they're there for that emotional support. There are many times that a resident is admitted and they simply get dropped off, and the substitute decision maker or family member leaves. And this makes settling in really, really difficult. So it is part of hopefully a responsibility of a substitute decision maker. They're also needed in times of crisis when quick decisions need to be made. And then, of course, at end of life. And again, those decisions at times are very difficult to make at end of life. And in our setting, remembering what the person's wishes would be. And again, I'll go back to being the substitute decision maker with my mother at the end of her life. Her wishes were comfort measures only. What does that mean? She didn't speak or communicate for a number of years, and it became harder and harder to know whether her wishes would have changed if she would have seen herself and been aware of her condition at end of life. And as her substitute decision maker, I needed to continually ask myself, what would she want? And so I will pause here by simply saying that in congregate living, we work best if there is a substitute decision maker who has been appointed, and if this person knows the individual's wishes and is committed to carrying them out.
Thanks so much, Elaine. And now moving to Laura, who's going to add in the hospice side of the equation.
Great. Well, thank you, everyone. I have to say that I'm gonna second what everyone has said so far, because you've said everything I had in my notes, which is great. But absolutely, if people can talk to their loved ones ahead of time so that your substitute decision maker or power of attorney knows what you want, that's best. There's nothing worse than getting into a situation and all of a sudden finding out your power of attorney or you're named substitute decision maker and you honestly don't know what that person would want. That definitely was not the right person then. And Elaine, as you were saying, the more that things are done ahead of time, the better. I love the fact that your mom wrote down her wishes in her own handwriting. What a wonderful gift for you, because you knew that's what she wanted. So absolutely. And I can think of times here at hospice, all of the residents, when we bring them in, require to have a DNR because we are not doing CPR on any of the residents. Absolutely. If a family member came in and had a heart attack, we would do CPR, but for our residents, no. But yeah, so if they've got the DNR, they've got a substitute decision maker. I can think of one resident in particular. The daughter came in, said, well, I'm the substitute decision maker. This is what we're doing. The resident still was of sound mind. So we had to sit that substitute decision maker down and explain that your mom still has capacity to make those decisions. So we have to listen to her until she's no longer able to make those decisions. We will speak to her. We can absolutely include the daughter in the conversation, but ultimately it was the resident who was making those decisions.
Thanks a million, Laura. I've done a miserable job at timekeeping here. So now I get to punt over to my colleague, Wanda, who will take you through the next question. Thanks, everyone.
Thanks, Deb. And I'm just hearing such delightful things from all of you and all things that we reinforce with our presentations. We hope and ideas for more that we can get into. I would like to give you the question of what should a person be including in conversations with their substitute decision maker to ensure that that substitute decision maker is prepared and equipped for this role. And so it seems to me that I'm asking you to narrow down a little bit of some of the information you've given us to some specific kinds of things. You've already mentioned some of them, but we're going to get into the details of each area if you can do that for us. And we'll start going the same order if we can. We'll start with Brenda.
So I would start with how you choose your substitute decision maker. I would reiterate what Anne said. If you have interesting family dynamics, even if you have really functional children, I have 3 of them. My daughters are very clear that my son could never take me off life support. I'm his main emotional support. They feel that there's no way he'd ever be able to do that. So every family dynamic is different. And if you have a lot of contentious issues in your family or interesting dynamics, I would consider making somebody who's not a family member your POA and get a legal POA related to that. 2 reasons. One is you want to get what you want. You want to make sure that the person that's actually doing the decision is going to be able to, has the chutzpah to actually follow up on what you said. But the other piece is you're going to pass away. And the legacy of the trauma of that left to your family is partly impacted by how they manage the dying process and the conflict that is developed in the family during the dying process. And if that conflict, you think that conflict is inevitable, I would recommend that you be really careful how you choose and who you choose, because everybody's going to grieve when you pass, but you don't want grief and guilt and anger and regret and all of those things. That's what makes grief. That's what makes grief a really complicated situation. So that would be the first thing I would say is really consider carefully. And then if it is your children, communicate to them why. That you're doing this because you want to, you trust them, but you want to absolve them of the longstanding implications of what this might be either for your family or for themselves. And the second thing I would say that probably speaks more to my actual experience is, as a physiotherapist, I spent most of my career translating for doctors. Because as a physiotherapist, my job was to talk about what people's functional outcomes would be. There's the disease process, and then there's what that disease process means to your quality of life. And not just what it means right now when you're being discharged from the hospital, but what it means going forward so that people can proactively plan. So when people are making decisions regarding various life support and what they want their dying process to look like, or the SDMs making that decision, the healthcare system will deliver it to you in medical interventions. But what you need to understand is, what does this person value? What are this person's values? What's their acceptable quality of life? And the decision isn't, do I want CPR? Do I want enteral feeding? Do I want to be intubated? The decision is, what is my acceptable quality of life? And how does the information that this healthcare practitioner is giving me fit into the context of that quality of life? So when I worked in ICU, and Lynn can attest to this, because there were a lot of families who the doctor would go in and say, family wants full code. And I would go and talk to them and they'd say, we want withdrawal of life support. And the doctor would be like, I don't understand. They were very clear, because the doctor went in the room and said, I think we can get them through this. And what they meant was, they will survive ICU. They don't mean they're going to recover to the same level they were prior to coming into hospital. And that's what people hear when a doctor says, oh, they're going to get through this. The doctor doesn't mean they're going to recover to the same level they were at before. Statistics are less than 10% of all admissions to ICU recover to an acceptable quality of life. Also, if you are maximally dependent for your personal care, your potential for surviving CPR is very close to zero, which means it's a medical intervention that probably shouldn't be offered, because there's very little scientific support that it would be of value to you. The reason that I was able to have conversations with families was because I would go down, sit down and talk about, what did this person's life look like before they had this acute illness? And it would let me tease out the underlying medical issues that probably hadn't been resolved. Sleeping in a lazy boy, they couldn't lie flat for 10 years. Probably means they have significant congestive heart failure. They're only able to walk from their lazy boy to their toilet. That's all they were able to do. If that person's intubated with cardiac failure, they're not going to survive and return home. If they survive, they're going to survive and go to long-term care. And when you frame it like that and say to people, people won't often say, I want this intervention, I want that intervention, but they will say, and no offense, Elaine, but they'll say, I never want to go to long-term care like my mom did, or I never want to go like Uncle Joe. I don't want to live like Uncle Joe lived. I want to go out with my boots on, and I just want to live at home. Those are the kind of things that they say. It's easier for families then if you frame it in that context and say, I used to say, this is the maximum I think they could achieve from a functional level, and this is the minimum level that they may end up at. If the maximum recovery is not within that person's acceptable quality of life, then all of the things we are doing to them in hospital are inappropriate, because we're offering interventions that are often painful and invasive and difficult to achieve goals that would not have been acceptable to that person. So the really important part when you sit down with whoever your decision maker is that they really understand your values. They have a vision in their head of what your accepted quality of life is, and that might be cognitive status, it might be physical status, it might be leisure activities, it might be relationship ideals. Everybody is slightly different, but they need a running movie in their head of what this needs to look like for this person. And then when you ask the healthcare practitioners, what you're asking for is, will this person achieve this? Is this intervention they're asking about going to help this person get back to this level? And it'll help you frame that conversation in a way that you'll have confidence that you are actually following through on that person's wishes as it's your job to do.
Thanks, Brenda. So we're going to go to Elaine and the long-term care perspective, and that the people don't want to go to long-term care because they haven't talked to you. So
Yeah,
that's what it's all about.
yeah.
You know what? I don't want to go to long-term care either. However, sometimes it's needed. And, you know, as I listen to you, Brenda, I really appreciate your perspective because it's so different. You're dealing with it in crisis, and sometimes we are too. But I think to focus just specifically with my comments on senior care and senior living, residents live with us. This is their home, and they're sometimes not with us very long, but at other times they are with us for a long period of time until they reach end of life. And so in conversations, I think it's important that you really talk about with your substitute decision maker all of your wishes for end of life and what that looks like. And also to recognize that the substitute decision maker understands that this is a significant responsibility and it's a significant time commitment. And this can take a lot of time as you are having conversations for a year or two, or in my case, it was 9 years in long-term care that you're part of emotional support and then making decisions. And so it takes a lot of time, and recognizing as a substitute decision maker from a congregate care setting, legislation requires that we call you every time there is a change, even a small change, a change in medication, if there's a fall, if there's any kind of an incident, and you are involved significantly in the care of your loved one and the person you've taken this responsibility for. It's already been said, but I'll say it again because we see it often, that if there's more than one substitute decision maker, it can be difficult, especially if they don't agree, or one or the other has perhaps not been as involved in the care decisions or in the discussions. And so when you're determining your substitute decision maker, it's really important to identify who is going to actually make the decisions, and that person will follow what you wish to have. End of life, talk about end of life. And while this is going off topic just a wee bit, understand that at end of life, the decisions then go to the executors, and that changes. So make sure that that path is clear, because there's all of a sudden the substitute decision maker is not making the decisions any longer, unless they're the same person at end of life. And, you know, having just gone through this myself, my mother had remarried, and all of a sudden there was a second executor. I was one, but there was a second executor involved, and it worked out very well, but it might not have. And so just being clear on what all of your wishes are is incredibly important. We also get into finances because people live with us. And it's important as well to help your substitute decision maker know, do you want to spend your money on a private room? We've seen situations where someone goes into a basic room because the family chooses not to spend money on a private room. So it's really important to be clear. And I will share just briefly one story that just is truly a success story as a substitute decision maker, and families were involved. A gentleman who lived with us in our retirement home. And this is actually a well-known story because he made it, he shared it with others before his death and after. And this gentleman was clearly at end of life and was considering MAID. And this was difficult for the family, who were substitute decision makers. But they were so supportive. They made sure he had all of the information on what end of life would look like, if he chose not to have MAID, what it would be like. If he chose MAID, they were by his side every step of the way, and clearly had his best interest at heart, and clearly set aside their own beliefs and their own ideas on what this would be like. And the experience at end of life was, it was a meaningful experience for, I believe, for him, for his family, and for all of our residents, because he included his community in some of his decision making and why he made decisions. And so the more communication you can have when you live in a congregate setting, and the more you've talked about what your wishes are with your substitute decision maker, just makes that journey so much easier. And so I guess my key word would be here: choose a substitute decision maker who you can trust fully to follow your wishes.
Thanks, Elaine. And we'll go to Laura with her perspective on hospice again.
Okay, so again, everybody's saying what I was going to say, and I expected that, but definitely having conversations ahead of time. And to Elaine's point, choose someone who is going to follow your wishes, not their wishes, but what you would want. And, you know, talk to them as much as you can. Start early telling your loved ones what it is that you would want. Let them know who you are, what your wishes would be. And as Brenda talked about, you know, if you were to go into hospital and you're going to get back home, but you're not going to be at the same functional level, would you be okay with that? So those are all really important things to discuss with your substitute decision maker, so that you know that they know what you would want. So I think, you know, those are the important things. There's nothing worse than having a substitute decision maker making decisions that family is now saying that is not what mom would have wanted. So, like I say, just share, talk about it. The more you can discuss, the better.
Thanks, Laura. And I think we're going to go to Shelley now with questions, or no, Patty?
Anne.
And you forgot Anne.
Oh, I'm
Wanda.
sorry, Anne. I'm sorry. Apologies.
Oh, not a problem. One thing that I'm hearing is everybody gives their perspective from their roles is about the language. And I think so often that's something that as healthcare providers, we're not always good at, because of the jargon, because of the lingo. We understand as our collective what we're speaking, but when it comes to our personal experiences and our family that may not have the healthcare background, making that language accessible and understandable and breaking it down into sort of pieces that are able to be consumed, because this is such an overwhelming process. You know, when there's been a healthcare concern, whether it's, you know, imminent end of life, that we can only take in so much information under stress. So as much what Brenda said about the ICU environment, you know, two people in the same profession can come away with two completely different results because of the understanding and ability to understand and other stressors at the time. So definitely for substitute decision making, those conversations are so important. And I think having that feedback, so asking, you know, this is what we've discussed. What do you understand of that? Or what's your interpretation? Just to make sure that everybody is on the same page. Now, from a personal note, my grandmother, she definitely had an extended dying process. And it was much to that thing of the interventions, maybe not fully understanding, because her quality of life was poor, but then there was an extension of her care. the thing with her long-term care, she had a great support system there. They were our extended family. And I think her preference would have been to stay there rather than having an extended stay in hospital and then return back to her family. But in saying that, it provided a great opportunity for our family, because seeing those different aspects of healthcare, my parents are both very private people and don't always open up with those discussions, but it gave my brother and I the opportunity to say, how are you feeling? We knew they were feeling poorly, but what did you think about this? Have you and dad made plans? You know, we should know about this. And it opened the discussion up. Then they were coming to us within a week or so. And it was little things at first. You know, my mom's like, I would like music. Music is so important to me, and make sure I have chocolate. But that progressed into, what are your funeral arrangements? You haven't discussed that with us. What would you want? And we found out my parents have very different wishes, but they agree and support each other, which is key. And if at some point they're not there, my brother and I now know, and we have a plan that we can carry out for them. They're unique, they're individual, but I feel a sense of value that I'm able to do that for them at some point if needed. And I'm glad that they've had the discussions. You know, that's what it took, was to have a few awkward family moments, but we've got a package made now for each of them. We have their medications together. So in the chance that there's an emergent situation, they have a copy of their health card, a list of their medications, previous surgeries to start that process, but then we have that list as well. My father is a farmer. He can't imagine being in a situation where he was bedridden and not active. My mom is happy to have music and contentment and be able to read. You know, there's such different levels of what our expectations for quality of life are. But if family knows and has these discussions, they can communicate that to the healthcare workers. You know, even I think as paramedics, we might be in that for a brief moment. We know our systems are busy waiting with the client at the hospital, but we can try to make them as comfortable and meet their desires as best as we can. So please have those discussions early, and start off slow if needed. It's not something you want to dive into maybe on an evening and set aside 2 hours, but having frequent conversations and checking back in, I think, is so important.
Thanks, Em. And now I think we're going to questions.
That is, the Laura and I are sharing our little spot here. That is a perfect segue, Anne, when you said that your parents used your grandmother's illness as a catalyst to have the conversations, and that you and your brother jumped on that opportunity to have those conversations. It's a perfect way to start a conversation. So now I'd like to ask our 4 panelists, what little secrets do you have? What do you know that we all need to know when it comes to navigating the healthcare system and advocating on behalf of our loved ones? What secrets do you have to work through the system that you're in? I'm going to switch you up and go backwards in order. So I'm going to pick on Laura first to
Oh my
answer
goodness.
that question. What are your secrets, Laura?
Oh my goodness. I honestly not sure how to answer that. I think the big thing is just getting in and starting to have those conversations. Obviously, when residents arrive here, it's end of life. That is why they're here. So we hope that they have everything planned and ready to go. Reality is, not everyone does. Not every family likes to have these conversations and plan ahead of time. They show up. We've had, just recently, we had a resident who passed 7:30 in the morning. By 4 o'clock in the afternoon, they hadn't picked their funeral home yet. So we had to sit down and have that hard conversation with them that these decisions had to be made. We went through different funeral homes that were available, where they were located, how things would happen. But again, you know, I don't think there's any magic, quick, do this, do that. Definitely conversations ahead of time are of the utmost importance. And just be there, listen, and, you know, be a person they can come to, I think would be my word of advice as a healthcare professional. If you've got families that are dealing with these, they're in high emotion. As the healthcare professional, you are not emotionally attached. So you hopefully can have some of those conversations, start off those conversations, And obviously, again, the earlier, the better.
Thanks, Laura. Elaine, what are your tips for navigating your system?
I'm not sure whether these are tips for navigating our system, but a couple of things that haven't really been spoken to yet. And the first is that I think it's important for all of us to respect the resident. We've touched on capacity and the importance of people being able to make their own decisions as long as absolutely possible. And in our setting, that can sometimes change even from day to day. But be respecting the resident, respecting the elder, respecting the individual. And as healthcare professionals, we have to be very careful to direct our conversation to the senior who's in our care. And it's so easy to slip into that mode of speaking to the substitute decision maker. And so it's hard. And, you know, I have to say, even as a daughter, it was hard for me not to jump in and voice what I thought were my mother's wishes without allowing her to give them herself. And I did ask our team, what are the things that are important? And this was one of their responses, is sometimes, and they actually, with all due respect, referred to physicians and people who are anxious to get that care completed, make that decision, move forward quickly out of need, and will jump directly to the substitute decision maker. And so I'd encourage all of us who are substitute decision makers to direct the conversation back to the senior. Pulling them into that conversation as much as possible and allowing them to respond. And the second thing that I will mention, and this came from our team when I asked them the question as well, is involuntary separation. And I realize this topic isn't involuntary separation, but it really is tied in here, that this is a challenge, especially if two partners, a husband and a wife, need to be separated for care and live in two different locations. For example, long-term care and an apartment. This can become very expensive. And when we raise the question of involuntary separation, it's important for people to realize and to be educated on this, to realize this is to provide financial relief only. And many times, couples who have lived together, and even their children, we had a son who said, we'll never allow that to happen. And they're appalled at this idea. And it's really important to remember that it's involuntary separation, and the couple is not separated in the eyes of the law. It's simply to be able to provide that care that's needed and bring some financial relief.
Yeah, I like that you really stress the respect factor, that when you have to, as the substitute decision maker, trying to answer questions, just think respect. Brenda and I worked together for many, many years, so I know she's got lots of little tricks for how to navigate the system.
Yeah, it's honestly, this is a hard question to answer because it's hard to tease it down to a few things. This is a really complicated system. But one of the things I would say, reiterating what Anne said, is knowledge is power. No matter how much you think you have it together, when somebody you love comes to hospital, it's almost always in crisis. And you're going to have a difficult time separating your love, your fear, your grief, your unresolved family dynamics, the fact that you're going to have to clean out their house. There's a whole lot of other factors involved that are going through your head as you're trying to navigate how poorly we give you information in a way that you can understand it. Doctors will always default to the correct medical answer because they are trained to answer exams on medical tests with the exact right information. But what communication is actually measured by the degree of understanding that occurs after the conversation. And if you don't understand any medical jargon, then there has been very poor communication. So most of us spend more time picking what snow tires we will put on our car this winter than we do in planning for our eventual health decline, and what that looks like for ourselves and our families. You will not manifest your death earlier by actually gaining appropriate knowledge and making appropriate plans. What you will do is give yourself and your family the freedom to focus on relationship, meaningful time, and a dignified death process without being distracted by all of the other uncertainty, questioning, doubt that occurs in those situations when people are put in those situations. So that's what I would say is, don't rely on the healthcare system to do a good job for you. Take the power into your own hands. Seek all the knowledge ahead of time. Have the conversations. Create a plan. Create a folder with all your information, as Anne talked about with her parents, so that when you get that crisis call, you have your questions prepared. You have your information prepared. You're all ready to go, right? That would probably be my best advice, because that way, when you get into crisis, you have a confidence and a calmness that you already know what you need to do. And that the best way you can love that person is by helping them have the little bit of control that they have left, by choosing what their dying process will look like.
And that comes back to the respect factor again, just respecting that person, as you said. So Anne, your role, the paramedic role, has changed so much over the last few years, very recent years, really. What little tips do you have for us?
Well, there's been so many points covered, but one thing that I came back to listening to everyone was a training session that I went to last year, and they talked about the 3 Ps, and it was being polite, being prepared, and being persistent. And it does tie into this because, as Brenda said, the emotion, when there's an emergent situation or there's an acute illness, sometimes to take that moment and have a breath. We all intend to be polite, but the overwhelming facts we need, the information, if we're not prepared, emotion can take over. And preparedness helps, but when that is not, I think the persistent piece is important. It's asking questions. When you're uncomfortable, it is okay to ask questions. I don't understand this. Tell me more about this. Could you explain this so my family member understands as well? We are in a healthcare system that is busy, but there is nothing wrong with asking those questions and being direct. And clarification is so vitally important, I think, when we're dealing with medical issues and procedures, because it's confusing at the best of times, but then when there is stress involved, I think those are sort of, I often go back to that. And our role in community paramedicine has changed in that we are seeing more clients who are prepared because they're having these discussions earlier. And I think there is more knowledge of hospice. There's more knowledge of, DNRs, conversations, planning, but we have a long way to go, certainly.
Yeah, I like your persistence point. That I know my years working as a nurse, I would say to families, I didn't learn this overnight. This isn't my loved one we're talking about. You need to keep asking until you understand it. And you might have to ask 4 people until one explains it in a way that you can get it. But that's okay. And that's your role as the substitute decision maker, is to keep on it.
Sorry, and one thing I just wanted to add based on what Anne said, which is true, is I don't want to sound like Debbie Downer and I'm trying to off everybody. The reason I'm coming this perspective is because the acute care hospital system will almost always, if they make an error in not honoring your wishes, that error will almost always be providing more care than you wished.
Yep.
So if your goal is to not have acute care and to limit interventions, your substitute decision maker is going to have to do is exactly as Anne said, is be persistent in advocating for those wishes and be prepared to be persistent. So pushing back when the doctor says, do you want CPR? The response should be, will it help them achieve this outcome? Which will put them back on their heels because they're not used to that. And they'll have to say, well, probably not. And then if you say, then why would we do that? Like, why were you offering that if that's not going to get them the outcome they want? That will help them frame an understanding of what your goal actually is. There's no wrong answer here. If your loved one or you are a person who want to be sustained, completely physically impaired, as long as your thinking memory is intact, or whatever your quality of life is, there is no wrong answer. It's just making you aware that the healthcare system will almost always default to providing more care than you actually wanted.
Yes, that's a very valuable point for people to take home and remember. So now we'll go back to Shelley.
Okay, well, I've got lots of things here. I have, a few things that I've heard people say. That preparedness, for sure, came out loud and clear. Choosing wisely who your substitute decision maker is going to be. And I think there were lots of examples of why that is so incredibly important. That partnership that Elaine talked about that you have with the congregate setting, but also with your healthcare providers. I mean, there's definitely a need to work together. And Brenda, I have the movie in my head is a great analogy. I'm going to keep that. What is the movie in the head about my loved one that I need to remember as I'm trying to work through the decision making? And your last point about, will it help them achieve whatever that outcome is that you have? Those are great points. The conversation about the DNRC, the do not resuscitate, but also the comfort care, all that language piece was also covered, I think, really well. And I know Anne and I have had conversations about the DNRC lots of times, especially it always comes up when we go out and do presentations. So there was a lot of information, great information shared. I don't see any questions in the chat, but we have lots of time if people want to turn their video back on, and if they have questions, they can raise their hand or use the icon on the bottom of your screen. We can do it either way, but if you have questions, this is the time to ask. Oh, I do have a question. What should the family have in that package that you talked about, that packet? I think it was Brenda that you talked about it.
Yeah, so for sure, if you actually have POA documentation, bring that copy with you. And I mean, Anne talked about what her parents had prepared, and that's actually really excellent. Your medical history, medications, and if you have, as Elaine's mom did, like actually a written document of somebody's values and quality of care, that's actually really valuable as well.
Okay. Brenda, did you want to talk? This may be a time just to mention about the portal. You had mentioned that the other day.
Oh yeah, so Grand River Hospital is starting a patient portal. It's starting in a small access. So legislatively, every patient should have the right to look at their medical chart. It's their medical chart. Right now, you have to actually come into the hospital and get the information pulled. But across the states, it's actually legislated that patients have electronic access to their documentation. So there's a patient portal access for St. Mary's and Grand River coming out. I think they're actually started already in November for a few key clinics, but they will eventually be evolving, where when people come into hospital, they will be given the option and instructions of how to access their own patient portal. They'll get lab values in real time, medical imaging in real time, access to some physician documentation. And one of the things I raised going forward that we don't have capacity for yet, but I hope we do in the future, is for patients then to go on and upload their POA documents onto their own patient portal. So it's already stored in the system, and they control that they've uploaded their most recent documents. So I'm hoping this is coming. I'm just raising it so you're aware that it's coming, but it will greatly empower people to be able to access their own information. And you can, by proxy, give your code to your substitute decision maker so that they can access your chart as well. I know we tend to think of this as a seniors thing, but just for your knowledge, there's no healthcare consent age. So for the portal's purpose, the age is 12. If a child is over 12, they have to give permission for somebody else to access the chart, including their parents. But I just wanted to let you know that that is coming, because it will roll out more over the next year, and it will play into this because people will have a lot more active access to their actual chart.
Excellent. That's exactly why I wanted you to mention that. Janet, I see your hand up. There is one other question, but is this related to what Brenda just said? Okay, so I'm going to let, we'll deal with, there's just a question about clarifying involuntary separation, Elaine, and then we'll go back to Janet.
And I'm not the expert on this, but what I will say is it is couples who have lived together, specifically in many situations coming into our home, there might be a husband and wife, and one or the other needs to move into long-term care to receive more care. The other is still living in their own home or an apartment. And we, as financial plans are made, it's often not anticipated, but that is a significant increase in cost if the two individuals have been living together in their own home, and now you're still having to pay for the home for the one spouse to live in and long-term care as well to make the co-payment. And each situation is different with regards to finances, but in order to get some financial relief on that, the individuals need to declare an involuntary separation. It's simply paperwork that has to be done, and then financial relief is offered. And certainly from a legal perspective, there's more information on that. And from a financial perspective, I don't want to delve into it more than that because it's all very individual, but just being aware not to be to recognize that the term is involuntary separation, and it's not that under the eyes of the law. That's the piece that people have trouble with, and we can help with that, but it's important to be educated and to understand that this isn't you becoming separated after 60 years of marriage, that it's simply for financial relief. So it's a bit of an evasive answer, but important to look into it for sure.
Yeah. And Elaine, who would you look into it with? Is that home and community care? Is that your doctor's office? Is that?
You could certainly look into it with home and community care. That could be a starting point. It would also be good if you are dealing with a lawyer with regards to your power of attorney, substitute decision makers, to have those questions. And we could certainly probably get more information on that from a long-term care perspective as well that we could provide for you.
Thanks, Elaine. Janet, nice to see you again. You have a question.
I do. I want to go back to this packet that Brenda's recommending. So I've got my POA documentation, medical history, medications, written document of values and quality of care. Substitute decision maker. Is that information supposed to be in that packet too? And let me ask something else. The DNRC, I understand I'd go to a nurse practitioner or an MD for that. Where does a lawyer play into this? Do I pay $750 and sit down with my lawyer and get a really good POA? Or can I just print something off the internet, fill it out with Terry, and ta-da, we're done? I need to think through a whole bunch of things. You've made me aware of that. I'm going to miss some things. Is a lawyer going to hit them well? How do you know who my substitute decision maker is? Should that be in my packet?
So,
Is
yeah.
that also a document that needs to be filled out in a certain proper way?
So you have one or the other. The only thing that's a legal document is the power of attorney. You can go on Government of Ontario actually has a package you can download, and it's actually what we distribute in hospital that costs you nothing, that you can actually do a legal POA with. So you don't actually need a lawyer. If you have a super complicated family with lots of dynamics, that would be the case when I would recommend you might want to get a giant amount of paperwork from a lawyer and pay that fee, but you don't actually have to. There's actually a really good, on the Ministry of Ontario, there's actually a really good document that you can just print off and get witnesses to sign and designate. If you don't have a POA, then it's the Substitute Decision Makers Act. So I would encourage you to go online and Google Substitute Decision Makers Act and actually have a look at what that legislation says. There's a defined hierarchy that starts off with court-appointed guardian. So this would be if you have somebody, often somebody who had like multiple disabilities from a child age on with no family would have a court-appointed guardian. They always trump everything else. And then it would go to spouse or partner. And then the next level is parents and children. So if your parents are alive and you have children, they would all be substitute decision makers and they all have to agree. If you have 12 children, I would encourage this is not the route you should go. So depending on your dynamics, and as I said before, if you don't have children and you don't have a spouse, but your closest friend is the person, you absolutely need a POA because that friend cannot be your substitute decision maker. They are not on the hierarchy.
And I just want to add to that. The Ministry Attorney General forms, very straightforward, but I totally agree with Brenda. I don't encourage those forms if you have any kind of complication in your family, and who doesn't.
Yeah.
There is another option. Community Legal Education Ontario worked with the previous executive director of the Advocacy Center for the Elderly, and she's a lawyer, and they created a free online tool that actually walks you through not only your POAs, but your will, and actually does some teaching and coaching along the way. And those documents can be printed and witnessed correctly and are legal. And you just have to, I can put it in a response. It's called Steps to Justice. If you Google Steps to Justice POA, it will come up. And it's through Community Legal Education Ontario, so CLEO. But if you just Google Steps to Justice Power of Attorney, it'll come up. It was a tool that was created just at the beginning of the pandemic. So, but it's free, and you could go in and, use a fake name if you want to just practice, but it's there as well. So I just wanted to raise that too. And we can send you a copy of the hierarchy. Some of you who've been in other sessions with us probably have already had it. But Brenda's right. You should understand where your person fits on that list, or who it would be if you do nothing. So
I'd like to jump in too and say, please do not ever give away your original power of attorney document. Make 10 copies of it, and that's the one you give away. Don't give away the original. Keep that one. Things get lost.
Anybody else have any questions?
If there aren't questions from the group, I'd like to ask Anne a question and whether she sees this. It was something I just became aware of because we don't run into it in congregate living, is the Edith document. Do you see that often? The expected death in home protocol.
Typically, our frontline paramedics up until recently have not seen it. They are familiar with it. Where we are seeing this increasingly is our palliative approach to care. So since May this year, our paramedics have been enrolling clients who are in the community and have a palliative care plan. They've worked with home and community care. And if they have either a DNRC, an Edith plan, both, those will be in the home care binder. And those clients are enrolled. And the goal of that program is essentially to provide symptom management. So if they are under the care of a palliative team, and for some reason they can't get a hold of their nurse, the practitioner, and they're symptomatic and they really want comfort, they can call 911 and the ambulance staff will arrive. The paramedics have been trained in different palliative techniques, not only medication, but as well, trying to, repositioning, comfort, and oftentimes those calls too are reassurance for the family. And it's that community piece where they're really being supportive. And then the paramedics will reach out to home and community care, to the palliative team, and let them know what's been done. And typically those individuals are wishing to remain at home but supported. If there's a need, if there's something reversible and they need treatment, we can facilitate that as well. But we're really just having the EDIF plan that we're seeing that more now in the home. And I think we will see more of that as there continues to be access to MAID in the community, and how community paramedics are supporting physicians in delivering that care as well. I think it will become more prevalent even a year from now.
Mm-hmm. Thank you. I think it will be a very useful document. Like, it would be good for people to be aware of it for sure.
And I don't know if you can speak to that, Laura, in terms of the EDIF protocol, but that's been around for a while. Used by the palliative care, pain and symptom management, the home and community care palliative teams to actually really plan out what that death will look like in the home. And I don't know, I know you worked in the community, Laura. Do you want to talk about it?
I definitely worked in the community for a long time. And yeah, I remember the EDIF papers coming out, and we would start to fill them out. And as one of the team, especially if you were covering for another team, it would give you some of those information. So in a crisis, you wouldn't be asking family, what did you want when this happens? Who are we contacting for this? So it's just a case of having all the information in one spot, like you say, in the front of the binder, right along with the DNRC.
Mm-hmm.
Okay, are there any other questions?
The only other comment I was going to make was, unfortunately, right now, palliative home care services are really, really limited. All home care services are really, really limited.
Mm-hmm.
So it's almost to the point where we're not even putting that out as an option to palliate at home, because we've had very little success getting enough services in place. At no fault of home care, they're having a horrible time like everybody else in healthcare, hiring staff, keeping staff, adequate staffing, right? So it's just not on the table right now for most people, unless you have a lot of involved family that can provide the 24-hour care supervision with just a little supplementation from home care palliative care services. There's not a lot of nursing PSW support available.
Which is not great news, is it?
No.
The way we're living right now. Okay, there aren't any other questions. I'm gonna let you go a little bit early, but I am going to ask you, first of all, I want to thank Anne and Brenda and Elaine and Laura for joining us today. There's a wealth of information. I think, Deb, you said it really well. And no offense, anybody, but there are a lot of years of expertise in this room, and we were very fortunate to be able to have them with us today. It is fascinating, and every time I hear you guys speak, I always go away with something I have to mull over. So thank you for that. I wanted to also mention the waiting room revolution for any of you who are into podcasts. This is a great podcast by a researcher and a doctor out of Hamilton that really, what their goal is to help the general public understand how to advocate and how to navigate the healthcare system when there's an illness. And it's their first season. I think they're on their 4th or 5th season now, but the first season in particular, they provided 7 steps for how to advocate and talk a lot about what Brenda talked about in terms of how do you ask, don't stop asking the questions, keep asking if you don't understand something, and that your role as a substitute decision maker would fit right in there. So that's available if you're into podcasts. I have just a quick poll I'd like for you to do before you leave, if you can, just to give us some feedback. And I also want to remind people that we are going to continue to do these online sessions and try and do some in person, whatever, depending on the COVID climate we're in. We are available to come out and talk to groups about advanced care planning about, we now have a consultation group if you want to talk to somebody one-on-one. We also are available to talk about hospice palliative care, and we just in the process of launching a course from Europe about last aid, which is helping people understand what that end of life, that dying process looks like, and what our role can be to help people, to support people in a non-medical way. So those are things you can always call us about, and I'm going to launch this poll, and thank you for being here today. Hopefully it shows up on your screen. Thanks again to our panelists, our speakers, much appreciated. You don't have to do the poll.
Somebody did briefly put in the chat, CPR after 85, not a good idea. So I'll just respond to that really quickly.
Yeah.
It's less about age, it's more about comorbidities. What are the underlying medical issues? And what's the potential for surviving that based on the underlying medical issues? So some of you recently probably knew with the pandemic that the province of Ontario had a triage tool that they developed related to who would have access to critical care. It was not well publicized that it was actually a system of objective measurement tools dependent on disease process that had really objective numerical scores related to potential for outcome. So it wasn't just a random, you're old, you're not going to get it, you're this, you're not going to get it. It actually was depending on your significant comorbidities. There was a whole series of different scales. And I was involved in mock trials where we actually picked patients and did mock trials of them to see how that would work in case we ever had to roll that out. And in my opinion, that triage tool should be used regularly for people because it actually gives a really good scientific basis for, based on your combination of disease processes, what your likelihood of benefiting from life support would be, which is really how the decision should almost be made, because it is a treatment intervention that should only be offered if it's going to provide benefit. So if it's not going to provide benefit, it is not a treatment intervention that should be offered. And it needs to be thought of as a treatment intervention because it is a medical treatment. That I would say the same thing for enteral feeding, tube feeding. It should only be offered if it's going to provide a benefit to the individual. So it's not really an age thing would be my best answer. It really is more about what your comorbidities are and whether that medical intervention would actually benefit you or not.
Okay, thank you. I don't know if you
I'm
can
just
see it
reading
in
the response here from Lori. She's indicated in the chat a little bit of information about my mom had a DNR, but my dad had it removed from the palliative care binder. So not something uncommon that we see as paramedics, you know, especially if people aren't agreeing on the same things or there's a personal conflict, but that DNRC is a legal document and those are the wishes of the family member. Unfortunately, because we do not have a provincial database, if paramedics don't have access to that document, they are obligated at this time by the Ministry of Health to initiate resuscitative efforts. So that includes CPR, that includes defibrillation. They're heroic efforts. And in a case where somebody's palliative, you know, most paramedics, they will initiate, but they will call either the palliative team, they will call our own physician and try to, you know, minimize the efforts on the individual. But that's really, I think, an important conversation if you're able to. I know family dynamics are unique, but to have with mom if she's able, as well as dad, and to try to have that document present if at all possible. I appreciate it can be challenging though.
It's how you frame it too. If you have a known palliative process, CPR or those kind of extreme interventions potentially slow down the dying process or increase the suffering of the dying process. They don't stop the dying. So people need to really understand. And I think people think, don't want them to die, going to have them do CPR. If they're already in the dying process, you're not stopping them from dying. You're just likely increasing the trauma or the intervention that's provided to that person as they pass away.
Dennis, I saw your hand go up. Quick question before everybody goes.
I may have missed this, but there was a reference earlier to a DNR form.
Mm-hmm.
And I've never seen a DNR form. Where does one access it?
Anne, do you want to address that?
Yeah, absolutely. So the DNR confirmation form, it's a legal provincial document. You can see a copy online, but they're not able to be completed or downloaded, but it gives you a visual of what that is. Your name, your birth date, your information is at the top, and it clearly states that you do not wish resuscitative efforts, and it has a list of procedures that you wouldn't want to prolong life. So being on a ventilator, medications, those sorts of things. But it also indicates that comfort measures would be provided by paramedics. So if there's anything reversible, so if you were diabetic and you had a low blood sugar, the paramedics would correct that. And I think there is still some confusion when people complete a DNR form. They think it means no care, or I'm throwing caution to the wind, no one will take care of me. But anything reversible can still be treated. Those forms can be obtained from your primary care provider, whether that's a family health team, your medical doctor, a nurse or nurse practitioner. They will have that discussion with you, and any one of those individuals are able to sign off and authorize the form. You can keep that at home. We recommend it keeping in a prominent area. I did mention in the chat earlier as well, copies are completely accessible. Like they can be used, they can be honored as long as you have that to present. So we do have individuals who keep a copy with their medication, but if they're traveling, they'll keep one on their person, in their purse, in their wallet, those sorts of things, along with a list of medications.
And just to clarify, Dennis, the DNRC is what you get, what you have out in the community. It's
Yes.
for the paramedics, that it's not something you carry into the hospital and that they use. It's for really that transportation from 911 call to whether it's a hospital or I know you can go to other
Although
places.
I would say if you do have it, put it in your packet to bring down,
Yeah.
because it does actually help clarify that it was important enough for you to do the work to
Right.
actually get this form filled out, which does speak to something. If you come in the piece that's important to know is on every hospital admission, you have to have an active order for DNR, which is why people are like, I was just here last week. Why are they asking me again?
Yeah.
And once I actually had a man say to me, woke up in ICU, he'd had a known living will. This was a long time ago when that was still a thing. And he actually was very clear that he never wanted to go to ICU. And then he reversed and ended up being in ICU. And when he woke up extubated, I said, what happened? He said, well, everybody kept asking me, are you sure you want this? And I thought I must be making a wrong decision because they kept asking me. But really, they kept asking him because every physician who becomes the MRP, the most responsible physician, wants to clarify, because they have to write an active order, that this is still the wishes of the patient. So they're not asking you because you're wrong and they think you're wrong. They're just asking you to cover their legal butt and make sure that they have an active order on the chart for each subsequent admission. It has to be rewritten. But it's very helpful if we have a background reference document that says you went to the trouble of stating your wishes, because that helps to guide the questioning, the conversation each time.
Yeah, excuse me. I understand all that. It's just a sort of a stupid question. Where do I get the form?
So if you have a family doctor, they would be able to provide you with that form. If you see various doctors because you were with a family health team, even if there's a nurse or a nurse practitioner that you're close with who's overseeing your care, if you ask, they will be able to complete that form or provide you with more information about that to see if it's a decision that you're comfortable with.
Okay, thanks very much.
All right. On that note, excellent morning. Thank you again. And thanks to the ACP team for your help in navigating this today. Have a good day, everyone. And I will send something out about our next round of sessions after Christmas. Thank you.